Innovation Network for Hour, a bi-monthly webinar series where we feature topics on e-health, information systems, and information technology for civil registration and civil statistics. Implement SNOMED CT and health record system, and then introducing it to the new hospital emergency department information system, electronic referral systems, and care for information systems in the succeeding year. So, the form, how to participate, and the email feedback. Event Center. If you have problems in joining, log out the session and rejoin immediately. Our 868-061-664 password. You might be in the meeting, but you can send your thoughts to us by icon. In your query, email evaluation form, so we can send the slides and all the resources of this meeting to you. It's Alastair Kenworthy. He works as sector architect on the New Zealand Ministry of Health Digital Health Team, represents New Zealand on the International Health Terminology Standards Development Organization member. He Health Sector Architects Group and is a member of the HL7 New Zealand board. With all of you, welcome Alastair Kenworthy.
And good evening if you're in my part of the world. Tēnā koutou means hello everyone, welcome everyone. Thank you very much for the chance to talk about New Zealand e-health program, our embracing of SNOMED CT as part of part of digital health. Thank you to the members of the Health Information Network, and to Alvin, Alia and Charisse, and also to Liara at ISDO. Not so terribly far apart. I mean, the Pacific region is quite large, but in ways, New Zealand, you might be surprised to know a little bit of a history with South Asia. Our indigenous people, the Maori, originated from the Pacific Islands, and before that, from Australia, people have been able to establish. So there are all sorts of links there, and in lots of ways we face the same challenges in our health systems and information technology. I wanted to point out that increasingly, Brunei, Vietnam, Malaysia and Australia are members with New Zealand of the Trans-Pacific Partnership with the United States for free trade in the region. So, New Zealand settled a mere 800 years ago by Maori. We see New Zealand depicted like this, lying on its side. It's rather odd, but that's probably the perspective it presents to the rest of the region. Just a little bit about the country, because you might be familiar. We've got a population of 4.5 million people. Is 230 billion, and very recently was quite close to a US dollar, very close to an Australian dollar, but the past few months it's 67 US cents, just to give you a perspective there. And of revenue, our public health budget is 17 billion New Zealand dollars a year. With your own countries. That's through that geographic regions around the country. We have a cultural society. The I guess dominate the numbers. The population Maori are about 13%, 7% Asian, around 1%, and a small number of other. Now, if you do add up the percentages, more than 100%, that's because in New Zealand we allow people to assign their ethnicity, if you like, and have multiple choices. Mineral wealth like Australia, for example, but we have resources. Our resources tend to be on top of the ground, and our sheep and dairy industries and our people. To talk about our population a little, most of our population live in urban areas. We have several larger centres. Our largest city is Auckland, which is about 1.5 million. We are a well-off country, but we have area deprivation both in urban areas and rurally. Because of our geography, it's a very hilly country. We don't have ubiquitous mobile broadband coverage. It's hard to connect the whole country digitally. In the country, we have different ethnic distributions and different health needs. We have problems that around the world do. We are an ageing population. Our population is ageing. Our workforce population is also ageing. I believe of doctors in New Zealand is over 50, and too. Growing emphasis in government on connected services across the health and social sectors, that very often health can't be addressed in isolation from social problems and those kinds of things. So we make public service more responsive to funding is one of our initiatives. It's probably a uniquely New Zealand initiative. It means family health. Whānau is about delivering social services to families that we've identified are in particular need. I'm interested that New Zealand has a goal of eliminating smoking completely by 2025. Like a lot of countries, we subscribe to the AAA aim, which there are goals in health care. One is better care for the patient, better and sustainable health system, better buck. Plans on the health information systems that we operate, we are responsible. We need them to deal with information that's comparable across health boards and even across countries. Operated a model where major investments in Health IT, the money 20 district health boards governed out of a national body called the National Board. The National has a number of advisory groups that you can see on the slide. We have encouraged the there's really far too many different bodies to work in our environment, to work as 4 regions. So we have 4 geographic regions across the country spending money on HT. The last 5 years has been in health IT has been built around providing all members of the population with online access to core health information about themselves. And this is predominantly information that is provided by their general practitioner. Portals have been reviewed, but it's been picking up quite recently. A public campaign. 1/5 of the general practices in New Zealand as of this month are now offering patient portals actively to their patients, and about 1,000 people in the population are now using them. So circles are growing out like a ripple and eventually encompass half the population in the yellow circle. National Health Strategy. So our National Health Strategy is centred around 2 key principles. One, care needs to be provided closer to home. King's Fund diagram will be familiar to some of you, which basically shows that healthcare individual centred around the home, and the high-cost enterprises free and used more sparingly than they are now. Strategy is to focus on early life and get a good start in their health and well-being, and but also reducing the potential for drain on the health system. Our problems in New Zealand is that we have high rates of a disease called fever, which very easily caught. It's a strep infection. Unfortunately, in some populations and in some conditions, it causes lasting heart damage. In New Zealand, and now I'm going to start talking about SNOMED increasingly, we are using policy to drive SNOMED up by health boards. We're using our national policy documents like a New Zealand Cancer Health Information Strategy, which was published just this week, to make very strong statements about the use of SNOMED CT as a tool for capturing quality information that drive improvements in the health system and for patients. So we've got the very strong statement that SNOMED CT is a system of clinical terminology distributed in New Zealand by the Ministry of Health and required in all clinical information systems. So there. And then in addition to cancer, SNOMED is the clinical terminology required at point of care when cancer patients are examined. So we have recently developed a national SNOMED implementation plan, and these components, I will be bringing out all of these things, so I won't labour them here. If you're not familiar with it, why SNOMED? The value proposition for SNOMED is use a system of terminology enabled to capture trusted and actionable information of care and use it downstream from that point. So precise information, it's actionable, you can actually do something with it. You can use interoperability in multiple practitioners are dealing in a single case. Not only you can also use it for population health management and for service improvement. In New Zealand, we're talking about introducing SNOMED at all points of care, and for the patient, and she's got self-monitoring at home, she's got medical devices, she's increasingly got needs around health literacy or opportunities there, and also a tool that can help us with that. A more technical perspective, SNOMED as a use of clinical technology is really just a space that enables to create various descriptions of conditions and their treatment. Classifying patients, grouping them, chunking them, they're actually describing exactly what it has, so that it can be personalised. The girl pictured here is in bed presently. She did ask me when I was speaking to this group, I said Asia. She said people in Asia. I said I don't know, a couple of billion. So she's got high expectations for this talk. What is, so some of you will be familiar with it, some may not be. So SNOMED CT is basically a network of concepts with automatically derived names, but they derive their meanings more from their interrelationships, so the relationships between clinical concepts. It's called a Kimball terminology. You can drive automated decision support and reasoning of information that's recorded. There is meant to indicate with the ski runs that there are multiple connections between different concepts. Now, I'm going to sweep all away and do an example of how this works. So, a very common condition, and it's usually a benign one, so I feel comfortable talking about it, is floaters, which is an eye disorder where you perceive in your field of vision little flea bits falling in front of your face. Now, people have shrapnel floating around in your eyeball, hence it's in your field of vision. So these floaters, that condition constitutes a condition in SNOMED. So I'm going to describe some of the concepts that surround that and give the thing its meaning. We have a synonym here, which looks like a Latin term or something, which is muscans. So that's a synonym, same concept. Which is a disorder of a vitreous body, which is based on eyeball. Vitreous body structure. Electronic health record, you know that the doctor you're seeing record perhaps any relates to the concept history of vitreous floaters and associated finding there is vitreous floaters. So I mean, if you had that in your electronic health record and you wanted to find out more about it, then really have all the hooks you need to a little bit of health literacy, little bit. That's a reasonably technical description, I guess, itself doesn't find a complete solution for electronic health record systems. In New Zealand, that was in a new HL7 standard, which you may be familiar with, healthcare interoperability courses or FIRE, can piggyback interest in that to paint these two standards as really the keys you need to get right to develop modern health IT applications. And just we've run a seminar which paired these things to HL7 FIRE and SNOMED CT were the key technologies you needed to get right to build a connected health ecosystem. Experience with SNOMED. Our first experience was in developing our New Zealand medicines terminology. And terminology, we've a universal list of medicines, which is really the online medicines terminology, and a formulary. Many countries have done this. The UK have done it with their DMD. I know that Singapore has done it, and Australia has developed a medicines terminology too. And New Zealand's medicines terminology is actually derived from the Australian version and its antecedents. The New Zealand medicines terminology is technically a SNOMED national extension. The medicines terminology basically identifies every medicine that's available in New Zealand and can be prescribed. It goes beyond that to drug interactions and indications, contraindications, and cautions. It also includes information about renal impairment, hepatic impairment, is national formulary originally. There's tremendous in a formulary. You can use T to identify explicitly each medicine, but you can also use it to identify indications and contraindications. While useful, we feel that we've gone probably a little too far in using national extension, and we're going to do with the SNOMED International release to internationally understood and for indications, contraindications, and that of more interest, emergency care, and we fear that New Zealand is leaders in this space. Our department clinical directors group, national group, and in 2012 that for new emergency department information systems in public hospitals, they would different sets to all the most common conditions that they see walking through the doors of an apartment. So from a modest-sized emergency department at was lead proponent of an emergency department information system, which was the first one in the country to use a set of 2,700 terms for describing and diagnoses in the emergency department. And set, again, we borrowed from Australia, we had use in New Zealand, and we went it probably faster than people in Australia. So that this picked up the country, and that appears to be happening now. hospital emergency departments, the work we're part of is vehicles nationally. There are service providers that on the development of tablet-based application that you can see pictured there, report form. It's a coded information. All the captures a clinical impression using terms about the patient. They capture about medications using terminology and capture information again using SNOMED terms for they perform. Reference set that emergency departments need. Ambulance only needs about 500 different concepts to describe the condition of patients. These occur most commonly. It's probably the sorts of things you would expect to see in somebody who suffered an accident, to things like fracture there, acute, and airway, intubation, those things. So, experience of creating reference sets to be clinicians are being unsure about SNOMED initially, but you don't get, creating a small reference set of 500 terms for ambulance does require quite a bit of work on clinicians to reference set to be useful for them. And in fact, the ambulance took the emergency department reference set and said, what's it that's going to work for us? What is easy to select from with very little time in such fast-paced environment? And in emergency departments and in ambulance, to get information in real time. So it's quite, and the richness that they're capturing not only makes for better care for the patient, but it gives them a lot more information about the services they're running. The size of the reference set is something that is a get right, I guess. The data we have so far is that if you have a reference set in an emergency department of 1,000 terms, you can cater for about 85% of. If you have a set of 2,000 terms, you're up to more like 95%. 4,000 terms, you've probably covered just about everything that's going to come through the door, right onto a snake bite or something. And there are in New Zealand a little morbidity audit and logbook tool use surgeons in college. I won't say that. We've been buoyed by our success with emergency care. It's a good example to show people, but now what I'm going to do is to take it more. We electronic referrals in the country to include a SNOMED coded clinical impression. We will clinics to SNOMED terms to describe their answers. And we have called patient flow, which is steering the patient journey through the process to secondary services. So a patient has been referred for work up because complaints of breath, then we can capture information about wait times through the public health system, through a first specialist assessment, through a follow-up, through any treatment. More transparency about the way our health system operates currently. Beyond realities to drive SNOMED use primary care information systems. Grail of the information and the general practitioner and use through the system is basically the furthest force information that is absolutely key information for any patient, information about their allergies, if any reactions they've suffered. Our National Telehealth Service, which is an 0800 number line, which with a nurse. So we some care, they spend $500,000 a year. However, we will hold with SNOMED powered information systems. Redeveloped 30 years ago for purpose. If you look for the most up-to-date specification on how to read codes, you're on the screen. It dates from over 20 years ago. The service owns the read code system and make a similar statement about withdrawing read codes as part of the strategy and new health IT plan. I'm at about half an hour, so I'm not going to talk a lot of Interi. I will one of the countries that implement my system for assessments for older people, and we benefit in aligning it with SNOMED. For us is developing the ideas of how you can create a powered app with convenient for use in busy environments. It's an emergency care, but the user face is not terribly sophisticated, and for investigating that further. One of the ideas we have a lot of innovative vendors in New Zealand, and there are others who run a design competition in the next little while. Record systems in New Zealand will all be powered. We're actually committed to that now, and we look forward to bearing the fruits of that commitment. I just want to talk about the mechanics of operating SNOMED in your country. The Terminology Standards Development Organisation develops SNOMED. It has a number of pieces shareholders. New Zealand was one of the first 9 countries. 27 member countries. They're and that it provides great support to, and increasingly it provides support just providing education, which is us in New Zealand to offer education to everybody who was interested, which was 30 people, which not terribly many. If you sat out to India, India has hundreds of people taking these courses. It really grows a community of people who know it and how to work with it. or it may be 28 countries. With Brazil, you'll see there are a lot in Europe, a lot in Asia Pacific too, and we attract them more. Member of the MEM forum of the IHTSDO. We met in Amsterdam last year, and I'm sitting next to Gaur Sundar from I've had around that table, and I can tell you what a fabulous they are to work with. Another provides is a member licensing and distribution service, which has just been released in the past. This is a lot easier for us in New Zealand to distribute SNOMED to our affiliate members. This is free to use in New Zealand, as in any member relationship with Ministry of Health's relationship with the IHTSDO. We have registered affiliates. We're hoping that number users of SNOMED. We also register software, and when they can't leave the deal they have, that they're able to use this intellectual property without cost for the price of having to register with us. Really no imposition at all. So the General Assembly, this is the chief governance body of the IHTSDO. The huge democratic organisation. So these people here are all representatives of member countries. The who are elected for the bills just from the health IT industry, and there to chief executive with the smooth running of the organisation. Now, for our New Zealand, because we've been selected the of next year's conference and expo for the SDO. It's always held in October. October next year will be coming to New Zealand to City Wellington to the conference. So words to our proposal, and this is engage with our health community to amplify SNOMED CT, the benefit of all peoples. Dr. Jonathan Coleman, our Minister of Health. So, we subscribe to that view wholeheartedly. This year, where the conference will be held, it's our museum Te Papa Tongarewa in waterfront. A very interesting space, and working events will actually be held in museum exhibit spaces, with it years since one exhibits there is about probably for it was which helped shape our nation 100 years ago. So this is actually a much more life-sized, three-dimensional figure that will still be in place when we have our conference next year. But the whole treasure trove of our country. Wellington has a lot of attractions. Not know, Wellington is actually the home of Peter Jackson's movie Peter Jackson, the director who created Lord of the Rings. More, he's King Kong and the Lovely Bones. And who's the director of Avatar is in Australia, and he's currently developing the sequel to Avatar here too. So we're proud of its film industry, but also a very strong software industry around a couple of companies, and much in Wellington, but in Auckland, our other main city, has an international presence as a health software vendor. We would see New Zealand developing another Ryan Health and exploiting SNOMED as part of their product suites. Proposed to the IHDSDO, we were more than happy when the Chief Executive, Don Sweet, to come and visit us to see if we were for real. His event manager, Fleur McBriar, and the attractions, and they were able to go away and report to the management board, and ultimately the member countries voted to that the conference would be staged here. 20 countries and a growing number, and is almost queuing up to join. We think a chance to host the conference as well, so we can make the very most of it. Minutes early here, but that might leave more time for questions. A couple of words of Maori, and Haere Rā means, and we very much hope to see you here in New Zealand in 2016 for
Thanks about SNOMED and the implementations in New Zealand. Now it's time to start answering questions sent by our attendees. So the first one is, how countries in Asia Pacific can implementation of SNOMED CT to enable health system interoperability? Where should they start?
I'm experience where we started niche, which we demonstrated to a clinical community who are the work, and that it was nothing to be scared of. And won a bit of a foothold out from there to get more of the requirements embedded in policy and more mainstream. So just at that point now in New Zealand, we're saying emergency care is fine, but let's go after referrals and let's go after primary care. So I'm suggesting that you start in emergency care, but I'm suggesting you start somewhere smallish and make a success of it.
Second question, what benefits of using SNOMED CT as a clinical terminology compared to using proprietary terminology or developed coding system?
Are sort of stock answers in that SNOMED is a more thoroughly developed terminology, it's computable, it's possible to do clinical decision support off it. But when you add a ready-made set of terms that you can work from, you don't go into a lot of debate about what should be there. You I guess, brand, if you like, you can do it with confidence and point to the fact that your international community who are doing this thing and pouring quite large sums in the development of the terminology effort. It's not a voluntary effort like a lot of the other things are. A7 is a volunteer organisation, for instance. So it's got sound engineering, and SNOMED CT developing the ontology from now based on everything we've learned. You may be differently at all. You couldn't think about anything else in the landscape.
All right, I have a question. I'm just curious, who's this set of technologies, and often are they updated?
Part of that question, please.
Who standardizes the set of terminologies in CT? Often are they updated?
Reference sets updated.
Yes.
The piece is refreshed every 6 months. And I guess a healthy amount of change from release to release. Often there won't be much impact. You adopt a ref set, let's say, for emergency care in terms or some perhaps retired. You just have to set the expectation that that will happen. There's nothing worse than having a scale of concepts which goes out of date. And a lot of practitioners in New Zealand are running codes which are 30 years old. The nations will tell you we have to, because it's the only way we're able to submit an injury claim to an insurer. So that's the reason for putting a read code in an electronic health record.
Okay, question. It reads, to see the national implementation of SNOMED CT is the ambulance service underway in New Zealand. What for future implementations of SNOMED CT in New Zealand?
We have some exciting developments going on. And what is very gratifying to see is that new software vendors are emerging. So with software vendors in general practice market, and you get a very high penetration of general practice. But our practice information systems market stagnated, and to see new companies coming in with a fresh attitude, much implement SNOMED, and they are starting to create software with systems out of the water. So primary information systems is base. These information systems are multi-practice, so that monitoring multiple clinics in the community, all that action is integrated so that they're repeating information at every contact. It's not the general practitioner or family doctor, it's a community nurse, it's a professional like this information. The major area of development for us.
All right. Question. It reads, do you capture chief complaint and present illness with SNOMED CT? If yes, how to do that? Yeah, and present illness with SNOMED CT?
Illness?
Churches complain and present illness with SNOMED CT. How to do that?
Might relate to presenting complaint, which is the patient's own description of the versus clinician might decide they're seeing. It always crops up. Do you feel that you've got accurate, well-described enough information to be able to assign a code or a concept to it? And I'm just text about that, which is the patient's own description of what their problem is. Different views on that, and I don't think we've reached a landing in New Zealand yet. I know we probably have a pretty good view on it, and we also the clinicians here departments who say that they believe that they can capture a code chief, which the own description of coming in for. Will create we use SNOMED terms to create their own clinical impression when the patient, and they'll at right to the point of a final diagnosis.
All right. So, other questions? It's a very good presentation. SNOMED is new to me. What is the difference between SNOMED and ICD coding?
Thank you, and thank you for the compliment. And obviously the World Health Organization, this is a product of the World Health Organization, is compatible a world which has SNOMED CT. So uses ICD-10. In fact, we use the ICD-10 Australasian modification, which is ACHI for describing interventions, like ICD that comes out of Australia. ICD is the statistical classification system for health at the of the mode of care. Discharge diagnoses, interventions that have been performed, statistical information, and means of accounting for the cost of delivering that service. But the purpose is certainly shouldn't be to get information which clinicians use in treating the patient. That's of SNOMED CT, which is much finer grained descriptions. It's rather than classifications.
I have a question. How long has implement SNOMED CT?
Well, charter members of the IHTSDO, when it was formed, and developing it as an international exercise in 2007, which our first SNOMED product was developed in 2010. That is really quite recently, in 2014, rolling national systems. So it's in hospital electronic prescribing and administration. It's in community prescribing that the new technology is being used. We signed up in 2007 or 8 with medicines terminology in 2010, and we started using it 3 or 4 years later. It's progress. We are demonstrate that now. We're much comfortable that our clinical community is on side and well connected with the international body. We're getting lots of support from other member countries and from the HTSDO to where we can now forge on. And New Zealand's interesting because we pride ourselves a little on to take a bit of some risks in what we do, and I think we do need to do that to make our health system sustainable. So our government's been talking about New Zealand as an ideal place to test its driverless cars. If we can have cars on our roads in New Zealand, we can certainly take some punts with SNOMED CT.
Progress. The most significant impact it had in all these years that you've been developing?
Is going to be the sector which most change. And the powered application didn't record about their patients. The ambulance treating the patient recorded information by writing it on their glove. And they've got their patient, they really hand and they're using that, and literally they're writing it on the glove. They're taking an emergency department at a hospital, and they look at their glove and they're talking to clinicians at the ED and they're saying, well, I gave them 50 milligrams of water, and you know, I did this and I did that, but it's not complete information. It's not people ambulance picks up injury cases, accident cases where claims need to be made. All that process requires a lot of duplication, re-entry, inaccurate recall from memory. The whole of delivering ambulance services is going to be transformed by this information, and nobody knows quite how far that's going to go.
It's still a good thing that you're using SNOMED CT in ambulance and emergency cases already. How long it takes for a health worker in the ambulance to do this, and how does it take to send information to the hospital before they arrive?
The pilot results showed that ambulance officers could complete electronic patient report form without compromising on the care they provide. It took them, you know, to complete the form, but I'm feeling of it's of that kind of order. If they're administering a lot of treatment, multiple observations of the patient, it'll be a little longer. Time for the patient is also going to we are around the country. In the urban areas, the transit time could be quite long. It could be 30 minutes. In areas, it's a shorter trip. So it's going to vary, and the system isn't fully rolled out yet. There'll be some interesting experiences. Half of that question.
So, here's the last question that we're having for tonight's session. It reads, a genomic database receives terms. We have ICD-9 mapping with SNOMED.
I have to admit that I'm not that familiar with the mapping to the procedures. In New Zealand, we tend to use the ACHI mentions code, which is closely related to ICD. So I'm imagining that if we have one available from Australia, we look across the ditch, as we call it, to borrow material from them.
All right, Ms. Christina, she said SNOMED CT has mapping to ICD-9 CM. Answered all the questions for tonight. I'd like to thank Alastair Kenworthy for taking our webinar for tonight, and have all enjoyed this lecture because it's insightful. Would you like everyone, Alastair, for next year's conference?
Are you here? We're proud of what we've done, and the family of HTSDO member countries will look that much better if some of the other Asia Pacific countries join. I think the will be a very good one. I mean, we're and we really want to make the most of it, and you are extremely welcome here.
For attending tonight's AHIN hour. Be reminded to check your emails for our follow-up message so we can get your feedback on this session. And once we receive your responses, we'll be sending more resources of this session to you. On August 12th, for another AHIN hour. Take care. Nice webinar.